Welcome to the channel. In this video, let's discuss about the autoimmune neurological condition called Myasthenia Gravis. Myasthenia Gravis is a rare acquired autoimmune disorder caused by antibody-mediated blockade of neuromuscular transmission resulting muscle weakness and rapid muscle fatigue. Let's go through the pathophysiology real quick. First, you need to understand how neuromuscular junction works. In NMJ, there are three main areas: presynaptic region, postsynaptic membrane, synaptic space, or synaptic cleft. In presynaptic membrane, there are calcium channels and acetylcholine granules. When impulses conducted to the presynaptic membrane, calcium channels open and influx of the calcium occurs. Then the vesicles containing acetylcholine start to degranulate into the synaptic cleft. In postsynaptic membrane, there are acetylcholine receptors. Released acetylcholine binds with the receptors to generate action potential on the postsynaptic membrane. In postsynaptic membrane, there are membrane-bound enzyme called acetylcholine esterase, which will degrade acetylcholine, reducing the duration of action of acetylcholine. In myasthenia gravis, autoimmune immunoglobulin G antibodies develop against nicotinic acetylcholine postsynaptic receptor at the NMJ of skeletal muscles. So the acetylcholine receptors in the postsynaptic membrane reduces, causing inadequate membrane potential generated at the muscles so that the muscle contraction doesn't occur. There can be various drugs may induce or exacerbate symptoms of myasthenia gravis. Antibiotics such as aminoglycoside, polymyxins, ciprofloxacin, erythromycin and ampicillin. Penicillamines. Beta-adrenergic receptor blocking agents like propranolol, oxprenolol. Lithium, magnesium, procainamide, verapamil, quinidine, chloroquine, prednisolone, timolol, which is used for glaucoma, anticholinergics, neuromuscular blocking agents like vecuronium and curare. Also, in most cases, thymic abnormalities can be seen as well. Signs and symptoms. Fluctuating fatigable muscle weakness. This worsens with activity and improves on rest. Ocular symptoms such as ptosis, fatigue of the muscles involved in eye movement. Weakness of head extension and flexion. Limb weakness more severe in proximity. Following factors can trigger or worsen the exacerbations: warm weather, immunization, emotional stress, menstruation, intercurrent illnesses such as viral infections, pregnancy and postpartum period, medications. Myasthenia Gravis Foundation of America clinical classification categorized myasthenia gravis into 5 main classes and several subclasses. Class 1. Any ocular muscle weakness. Weakness of eye closure while all the other muscles strength is normal. Class 2. Mild weakness affecting other than ocular muscles. Class 2A. Affecting limbs, axial muscles or both. Lesser involvement of oropharyngeal muscles, while there is involvement of ocular muscles as well. Class 2B. Affecting oropharyngeal, respiratory muscles or both. May have lesser or equal involvement of limb, axial muscles or both. Class 3. Moderate weakness affecting other than ocular muscles and may also have ocular muscle weakness of any severity. Class 3A. Predominantly affecting limbs, axial muscles or both. May also have lesser involvement of oropharyngeal muscles. Class 3B. Predominantly affecting oropharyngeal, respiratory muscles or both, and may also have lesser or equivalent involvement of limbs, axial muscles or both. Class 4. Severe weakness affecting other than ocular muscles and may have ocular muscle weakness of any severity. Class 4A. Affecting limbs, axial muscles or both. May also have lesser involvement of oropharyngeal muscles. Class 4B. Predominantly affecting oropharyngeal, respiratory muscles or both, and may also have lesser or equal involvement of limbs, axial muscles or both. Class 5. Need intubation with or without mechanical ventilation, except when used during routine post-operative management. Diagnosis: anti-acetylcholine receptor antibody test, anti-striated muscle antibody, anti-MuSK antibody, anti-lipoprotein related protein 4 antibody, anti-agrin antibody. Imaging studies such as radiography, CT and MRI. This is done for rule out tumors. Electrodiagnostic studies. Repetitive nerve stimulation. Single fiber electromyography. There is an important pharmacological test that you can do to confirm the diagnosis. You can use either IV or local idrophonium, which will improve the muscle weakness temporarily. Idrophonium is a short-acting acetylcholine esterase inhibitor. Idrophonium slows down the degradation of acetylcholine, which will increase the duration of action of acetylcholine. Management. Management depends on the profile of serum antibodies, the age of onset, the presence or absence of thymic pathology, and the distribution of clinical weakness. Therapy includes acetylcholine esterase inhibitors such as pyridostigmine bromide, neostigmine, idrophonium, corticosteroids such as prednisone, methylprednisolone, immunomodulators, azathioprine, cyclosporine, cyclophosphamide, mycophenolate mofetil, methotrexate. Immunoglobulins given IV. Monoclonal antibodies such as rituximab, eculizumab. Fc receptor antagonist. Beta-2 agonist such as albuterol. Anticholinergic agents such as ipratropium, glycopyrrolate. If there is any thymic pathology, we can do thymectomy as a surgical intervention. So that's it for the video. Hope this video would make sense. Thank you for watching.